We are live.
Good evening to all. I, Dr. Santosh Shirol from Medical Affairs team of Hematology at Takeda, would like to welcome you all for today's webinar. As a constant endeavor to facilitate scientific discussion on most up-to-date data in hemophilia and allied bleeding disorders, we at Takeda have initiated a series of scientific webinars from April. And today we are rolling out the third webinar of current challenges in the diagnosis and management of von Willebrand disease in India by Dr. Suresh Hanagavadi. We would like to begin today's proceedings by extending our best wishes to all the COVID warriors. Before we move on to live webinar, I would like to introduce today's speaker, Dr. Suresh Hanagavadi. He is one of the most eminent personalities in the field of hemophilia and blood-related disorders. He has a 26 years of extensive teaching and consultation experience. Currently, he is a professor working as a professor in the Department of Pathology at JJMC Davangere. He is a former president, Hemophilia Federation of India, founder and president of Karnataka Hemophilia Society, founder of Lifeline, a voluntary blood donors organization at Davangere. He is the recipient of several awards such as 10 Outstanding Young Indians, Red and White Bravery Award, Karma Veer Chakra, Carl Landstinner's Memorial RBC Award, the Best Wins of the Year, an international award, and Sri Murgashri. To conclude, he has published his valuable work in national and international journals. And now I would like to invite Dr. Suresh Hanagavadi to take over the session on von Willebrand disease and his experience over the same. Over to you, sir.
Thank you, Dr. Santosh Shirol. Good evening. Thank you all for participating in this webinar. And I must thank Takeda for organizing this scientific session on most complex bleeding disorder, von Willebrand disease. I am working as professor of pathology at JJM Medical College, teaching undergraduate and postgraduate students since more than 25 years. In addition to this professional work, I am deeply involved in not only diagnosis, treatment, and rehabilitation of inherited bleeding disorders, mainly hemophilia, but also developing the care services in this part of the state. And it is nearly more than 30 years we have been putting our efforts in bringing change in the hemophilia care. And why I have taken up this challenge mission is because I am also a bleeder. I have factor IX deficiency, hemophilia B or Christmas disease, and this is the one which made me to take up medicine and become doctor and do something for my blood brothers. To achieve this goal, I transformed I into we by forming an organization, Karnataka Hemophilia Society, and this team mobilizing resources from various sections of the society, including celebrities, paramedical professionals, and we have set up a state-of-art hemophilia treatment center in Davangere. And I am very happy and proud to share that hemophilics and other rare bleeding disorder, we are providing totally free of services with the support of World Federation of Hemophilia, Hemophilia Federation India, and our team. Today, I am discussing about the current challenges in diagnosis and management of von Willebrand disease because of this association, because of this my inherent commitment to the cause. Next slide. This is mainly an educational, informational purpose and to improve the healthcare in the country. Next slide. Next slide. I declare no conflict of interest for this scientific session organized by Takeda. Next slide. Yes, coming to what exactly is von Willebrand disease. So von Willebrand disease is most common inherited bleeding disorder. It affects both males and females from all racial backgrounds. It is inherited disease caused by genetic mutations that leads to decreased production or impaired function of van Willebrand factor. Yes, there are acquired form of van Willebrands also, but most of the acquired van Willebrand disease is caused by immunoproliferative disorders and autoimmune diseases. Next slide. Van Willebrand's disease, the credit should be given to the great physician from Finland who has a family of van Willebrand's disease, the bleeders family, and he describes the exact clinical features, including the family pedigree, in 1926, and he describes a severe bleeding episodes that in the members of family and in a small island between Sweden and Ireland. Bothnia, that small island. Okay, thank you, sir. The first reported case of van Willebrand's disease I must mention here. It is a 5-year-old girl presented with repeated nosebleeds. In fact, previous bleeds also when she was 3 years, she bled profusely from a deep cut and even leaving her unconscious and unable to leave her bed for 10 weeks. At 5 age, and she admits in the hospital for the loss of blood, severe bleeding from her nose. And unfortunately, at the age of 13 years, she died during her 4th menstrual period from excessive bleeding. This is a documented the clinical description by van Willebrand. And he also documents family history. In family history, both parents were having repeated nosebleeds, and there were 7 children in the family, and 4 of the female children dies of uncontrolled bleeding. And this clinical description, including the family pedigree, remains the same even till today. Thank you. Next. Coming to prevalence of van Willebrand's disease. So van Willebrand's disease is the most common inherited bleeding disorder. Next is hemophilia. So with a prevalence of as high as 1% in the general population. And it affects both men and women. And there are some population studies which have estimated at least 1 in 1,000 patients attending the hospital for the significant bleeding, and also severe disease is found in approximately 0.5 to 5% per million population. Coming to our country, there are some studies which gives the prevalence rate from 8 to 10%. 8 to 10%. There are 4 studies I have put here, which one, the first one 9.8%, and as high as 28.6%, the Gupta et al. Has shown us. Next slide. The Indian scenario is complex, and if you take the National Hemophilia Registry of Hemophilia Federation India, out of 21,824 inherited bleeding disorders, only 676 patients are registered with HFI. So that's why there is definitely a low rate of diagnosis. For this, there are so many reasons. Number one, most of the laboratories in remote parts of the country have no facilities for the diagnosis of van Willebrand's disease. And most of the Indian studies are hospital-based, small registry, which might account for higher proportion of severe form of disease as we see in the Western countries. And in addition to this, lack of awareness among healthcare professionals, especially our gynecologists, and unequipped laboratory facilities contributes to the low diagnosis among population and variation in the Western literature. And in addition to this, definitely there is lack of tremendous public awareness. And also, our women in the country, they do not come to the hospital unless it is a severe bleed. Unfortunately, the bleeding manifestation in Van Willebrand disease is milder form, and they suffer it. Thank you. Next slide. As I told you, it is a genetic disorder. The gene which is responsible to produce this Van Willebrand factor is located on chromosome 12. And chromosome, this Van Willebrand factor gene is expressed in endothelial cells and megakaryocytes, and it is produced as a propeptide. There are different forms: propeptide, prepeptide, and mature Van Willebrand factor. And this has to be translated to mature Van Willebrand factor to get the functional activity of carrying the factor 8 and adhering to the platelets. Thank you. Next. So, Van Willebrand factor production mainly occurs from the megakaryocytes and endothelial cells. And most Van Willebrand factor is secreted form. And some Van Willebrand factor is stored in the Weber-Palade bodies in the endothelial cells. And alpha granules of platelets also contains the Van Willebrand factor. And only to release all these factors, we need constitutive or stimulus-induced pathways, that is mainly the endothelial injury. And on this endothelial injury, there will be release of the substances like thrombin, histamine, fibrin, and complement complex C5b and 9, and especially the platelet release reaction on adhering to the injured endothelium and releasing some more the chemical agents like ADP, epinephrine, collagen, and thrombin. So ultimately, the primary hemostatic plug is formed. Next one. Let us see what is the role of Van Willebrand factor in the normal hemostasis. As I told you, the inciting process is endothelial injury. So once there is endothelial injury, the release of Van Willebrand factor occurs simultaneously, and it binds to the platelets, GP2B and 3A on the activated platelets. And Van Willebrand factor, it mediates platelet plug formation and platelet to endothelial adhesion. So ultimately stabilizing the hemostatic plug against the shear forces. So this is what we know as primary hemostatic plug. But it also takes part in secondary hemostasis. The main purpose is to stabilize the factor 8 coagulant protein in the circulation. So it is being produced and destroyed. But once endothelial injury, blood vessel injury occurs, it enters into the circulation and it stabilizes the factor 8 coagulant protein and leads to the cascade. That's why we say the Van Willebrand factor acts like a carrier for factor 8 molecule. Next slide. So this picture shows you how the activated platelets, the activated injured endothelium adheres to form a primary hemostatic plug. So that's why Van Willebrand factor is an important mediator of platelet plug formation. And also factor protects factor 8 from proteolytic degradation by stabilizing it, and it localizes factor 8 to the site of vascular injury. So here also you can see secondary hemostasis stabilizing the factor 8 molecule. And later, once the purpose is served, it is cleared by the liver. Okay, thank you. Next. Actually, the bleeding risk and Van Willebrand disease, it all depends upon the concentration of the Van Willebrand factor. You can see the normal population, it varies from 50 to 200 international units per deciliter, and mean is around 100 units per deciliter. And to bleeding to occur, the level is around between 60 to 50 international units per deciliter. And interestingly, the group O individuals will be having low level of this van Willebrand factor at least by 20%. So this is the level of van Willebrand factor determines the clinical manifestations. That's why there is a variation and a lot of discrepancy even in the laboratory results. Next. Coming to clinical manifestations of van Willebrand disease, there are four primary areas we need to touch upon. So these are the mouth and nose bleeds. So mucocutaneous bleeds are more common with van Willebrand disease, unlike hemophilia. So they may also bleed from the gastrointestinal mucosa, and in females, the manifestation may be menorrhagia, especially the puberty menorrhagia. And joint bleeds are uncommon in van Willebrand disease, and joint bleeds are seen only in the severe form of van Willebrand disease, that is type 3, where even the factor level is markedly reduced to cause joint bleed, as you see in hemophilia. Next. So these are some of the nose bleeds are more common: mucocutaneous bleed, gum bleeding, okay, and you can see ecchymotic patches. Next slide. So as I told you, joint bleeds is uncommon in van Willebrand disease, but in type 3 they may bleed in the joint. So because of the bleed in the joint, so naturally it leads to joint damage. Okay. The blood which is absorbed the iron pigment, which will irritate the synovium, which will irritate the cartilage and even destroy it, and leading to joint damage, as we see in hemophilia. But patients with the joint bleeds, they have lower health quality of life in addition to their other repeated bleeding. That's why the type 3 van Willebrand disease patients, generally the prophylaxis is advised to improve the quality of life of these patients. Next slide. Coming to pathophysiology of van Willebrand disease. So van Willebrand is an inherited disorder characterized by both quantitative defect as well as qualitative defect. So quantitative defect, the level of the van Willebrand factor is reduced, and in some patients the level may be normal, but the quality of the van Willebrand factor in various other forums, maybe addition to platelet, release, all these are all defective. So that's why we can say there is a delayed defective platelet adhesion is the main problem, and delayed defective platelet plug formation, and delayed defective fibrin clot formation. So that's why both the quantitative and qualitative defect are seen, and manifestations are also like that. Next slide. Let us look at the genetics and severity of van Willebrand disease. So broadly, we classify van Willebrand disease into three categories. That is type 1 van Willebrand disease and type 3, both are quantitative disorders, whereas type 2 is qualitative disorder. So this quantitative disorder in type 1, the van Willebrand factor level is reduced, whereas in type 3 almost nil. So that's why type 3 is severe patients. And the genetic transmission of most of the van Willebrand disease type is autosomal dominant, whereas type 3 is transmitted as autosomal recessive. And most common van Willebrand disease, as I already mentioned, is type 1. And the bleeding manifestations in type 1, it is mild to moderate, whereas in type 3, severe, even to the extent of having joint hemorrhages. Whereas coming to the qualitative defect categorized into type A, 2A, 2B, 2M, and 2N. And this constitute about 10 to 30% of the patients. And especially the A and B, they are autosomal dominant, whereas M and especially N is autosomal recessive. So these patients also will have bleeding manifestation depending upon their typical presentations types. Thank you. Next one. Three types of Van Willebrand's disease I have mentioned. The type 1, as I told you, less Van Willebrand factor. That means partial quantitative deficiency of Van Willebrand factor and factor 8 in the plasma. So 5 to 30% lower than the normal. So that's why they bleed on major challenges. Otherwise, mild bleeding episodes. Whereas type 3 is severe form, complete absence of Van Willebrand factor, and moderately severe factor 8 deficiency. Whereas the type 2 Van Willebrand's disease patients, type A is qualitative defect of Van Willebrand factor, but they lack multimers, ultraweight multimers are lacking. Whereas type B, platelet binding to Van Willebrand factor is defective. Platelet binding. Okay, that's why type 2B patient also will have thrombocytopenia, and they have loss of intermediate to ultra lightweight multimers. And type M is increased binding of Van Willebrand to platelets. That is the typical feature. Whereas the type N, 2N, is defective Van Willebrand factor binding to factor 8. So it is one of the differential diagnoses for hemophilia. So clinical appearance is similar to hemophilia. Next. What are the challenges in the diagnosis of Van Willebrand, especially in our country? So let us discuss this under these headings. What are the patient-related factors? So Van Willebrand factor level vary greatly. So Van Willebrand factor, even the physiological stress, the hormonal, estrogen, vasopressin, growth hormone, adrenergic stimuli, all these will definitely cause variation in the Van Willebrand factor. Okay. So the Van Willebrand factor levels vary with even blood groups, blood type, as I told you, O group individuals. So coming to the doctors, physician-related factors, first, a lack of awareness. They don't keep Van Willebrand's disease in the differential diagnosis of menorrhagia mainly, and not including Van Willebrand's disease in the differential diagnosis, as I told you, and low orientation with the hematological disorders and ignoring complete lab work. So lab also there are issues. So Van Willebrand factor levels may be normal intermittently in patients with Van Willebrand's disease. So it may be normal now. That's why we advise on 2 different occasions tests should be done. So that is another major challenge because of the variation of the Van Willebrand factor in the patient. And measurement, as I told you, it should be repeated at intervals of more than 2 weeks is advisable for the diagnosis. Then poor rate of diagnosis, poorly equipped laboratory. Most of the laboratory doesn't have facilities to go ahead with the evaluation of Van Willebrand's disease, mainly with the platelet aggregometry or Van Willebrand factor antigen assay and all those. And training of lab staff is limited, and lab logistics availability. Okay. So because of all these, we are not able to diagnose Van Willebrand's disease appropriately and provide optimum treatment. So overview of this, the clinical history and certain differential diagnosis and ultimately clinching the diagnosis. How do we go about it? Next slide. Clinical history and screening is very, very important. Individual personalized clinical history is very, very important. So especially the menstrual history in case of females, and probing of the family for the bleeding episodes in anybody else in the family and other bleeding conditions which necessitated transfusions and all those. So history has to be taken very carefully. Next slide. So these are certain questions we need to form, and these questionnaire which I have mentioned already, if they are positive, next slide. So we can do some screening test that is abnormal laboratory level, that is APTT or even platelet count. So all those, if these features are there, then we can go ahead. If this history doesn't suggest of any bleeding diathesis either in the patient past history or in the family history, no need of further evaluation, reassurance, and sending the patient is appropriate. And if all these problems are present, so then we should go ahead with the screening test. Next slide. So yeah, so this the differential diagnosis part, that is focus on strategy to exclude other common causes of bleeding. As I told you, mucocutaneous bleeds are more common. So you rule out some other diseases which can cause the similar it may be vascular pathology or platelet pathology. So for this, some preliminary investigation may be advised, which are available in any laboratory. Platelet count to rule out platelet disorder, both quantitative and qualitative, and make one peripheral smear, look under the smear for the arrangement of platelets, whether they are discrete or aggregate, and that will help you to think of any the functional platelet disorder, or even other diseases like acute leukemia or causes of thrombocytopenia can be evaluated. So the next investigation we generally ask is PT and APTT. So PT generally prolonged, as you know, in liver disorder most commonly, and that will help you to think of the diagnosis. And if there is isolated prolongation of APTT, then we have to be very careful. We have to consider Van Willebrands in the diagnosis. And bleeding time, generally we discourage this BTCT in most of our clinical laboratory practices, because the clotting time may be normal in mild form of hemophilia. That will not tell you anything. If it is prolonged, you accept it. If it is normal, don't accept it. This is how we tell our postgraduates. Whereas bleeding time, still we need to accept. And if you want to do bleeding time, you have to do with the modified IVs method. To some extent, bleeding time will help you, especially in the diagnosis of Van Willebrand disease. And measure Van Willebrand factor once these investigations are relevant. If Van Willebrand factor deficiency is not there, then you need not go further with the coagulation profile. Next slide. So one of the important differential diagnoses we need to keep in mind is hemophilia A, classical hemophilia, especially mild form of hemophilia. So because anyhow, for the sake of discussion, this slide will tell you, whereas bleeding time, yes, it may be normal, but generally Van Willebrand disease patient will give you prolonged bleeding time. And the bleeding manifestations are typical with hemophilia, that is deep-seated bleed, especially severe cases. You will have history of joint bleed, muscle bleed, and also it depends upon the severity of the disorder. Depending upon that, manifestations will be there. Whereas in Van Willebrand disease, unless it is type 3, there is no joint bleed, and only epistaxis, gingival bleeding, bruising, menorrhagia, bleeding from the minor cut or abrasion, post-operative bleeding after the tooth extraction. So bleeding occurs. So these are the common manifestation. Life-threatening bleeding, gastrointestinal bleeding, and hemarthrosis, they are, when you compare to hemophilia, that is rare. Next slide. So with the history, we can clinch, we can keep in mind certain conditions. Differential diagnosis I have mentioned about, especially hemophilia. So coming to the diagnosis of Van Willebrand's disease. Once isolated prolongation of APTT in a female or in a puberty menorrhagia, that has to be Van Willebrand's disease, and you have to plan accordingly. Suppose if it's a boy, then you have to go into the details of mode of inheritance and all those. So type 3, most type 2 variants are relatively easy to diagnose, because under type 1 diagnosis is problematic always, because distinction between benign polymorphism and pathogenic mutations are difficult. So sometimes we may have to genomic analysis also for the appropriate diagnosis, and several investigations may be required to confirm the diagnosis or rule out suspect diagnosis. Next. So this is the profile of investigation. Generally, we ask for the diagnosis of Van Willebrand's disease. In this panel, Van Willebrand factor antigen and Van Willebrand Rikoff ratio and factor 8 assay, and even the bleeding time and the platelet count and multimer analysis. These are the profile of investigation which will help us in differentiating the various subtypes of Van Willebrand's. Next slide. So what is the treatment of Van Willebrand's? So the modalities or the main goal is to stop the bleeding. So how to stop the bleed? So number one, because these are all milder forms of bleeding episodes, the first we give the preference to the non-blood products or some pharmacological agents which will elevate endogenous Van Willebrand factor in the bloodstream. So desmopressin is a vasopressin analog, ADH analog. In addition to its vasopressor activity, it mobilizes the endogenous Van Willebrand factor and as well factor 8. That's why desmopressin is very effective in arresting bleeding of epistaxis or percutaneous bleed. Even nasal spray, subcutaneous are available. And especially menorrhagia patients, we go for hormonal contraceptives to control the bleeding till they plan for the further treatment. And the second one, especially severe category of patients, we may have to go for replacement of the deficient Van Willebrand factor, or you say dysfunctional Van Willebrand factor. What are these products available? As in hemophilia, the plasma-derived factor 8. Plasma-derived factor 8 contains Van Willebrand factor. But anyhow, there is one caution note which I will tell you later. And because of the availability of the DNA recombinant technology, we have artificial Van Willebrand factor, that is recombinant factors. And the third one is promoting hemostasis and wound healing. In addition to this, yes, antifibrinolytic drugs. Antifibrinolytic drugs, especially the epsilon aminocaproic acid and this tranexamic acid, are found very effective, especially in controlling the bleeding from the gum. So, and topical agents are also there. So, we can use these medicines and achieve hemostasis. So, that's why these approaches are not mutually exclusive. So, it all depends upon, you have to plan the strategy. Next slide. So elevate endogenous Van Willebrand factor in the bloodstream. That is, I have already mentioned the desmopressin, and type 1, it is very effective. We can use desmopressin in the treatment of type 1. Type 2A and type 2M efficacious in some patients only, but type 2B it is not indicated. It is not going to help. Whereas type 3, it is ineffective because the factor level is almost 0, even severe form of the disorder, and these these non-blood products will not help in them. Typical maximal range usually you can obtain 2 to 4 fold for one Willebrand factor and 3 to 6 fold for one factor 8 increment, and only risk of tachyphylaxis is expected. Next slide. So coming to the replacement of the deficient factor when desmopressin is not going to be effective, and in some, especially type 2B, it is contraindicated, and in type 3 you have to go for the replacement of the deficient this van Willebrand factor. Next. And also during surgery we have to go for the coverage of replacement of these factors pre-operatively, post-operatively till the wound heals. Yeah, so these are the modalities of treatment available. So on-demand treatment. On-demand treatment means whenever they bleed, you have to use these medications to arrest the bleeding. Whereas there is one more gold standard treatment we call prophylaxis. So that especially type 3 bleed, who tends to have joint bleed, the prophylaxis is the gold standard treatment because it will not allow patient to bleed at all, and that's how it prevents disability, and it also improves the quality of life. So that's why prophylaxis is advised, especially for the type 3 van Willebrand disease. And also perioperative, yes, this is especially the pregnancy and managing the delivery, and also some surgeries like tooth extraction or even any surgery that has to be done under the coverage of van Willebrand factor. Next. So these are the milestones in the development of the van Willebrand factor or treatment of van Willebrand's disease, as we see in even in hemophilia. So in 1926, when van Willebrand mentioned about van Willebrand's disease, nothing was available, and later the blood transfusion became a best modality to replace the missing van Willebrand factor. But the cryoprecipitate in 1964 was the best available treatment product in achieving the normal hemostasis. But thanks to the technology, the 1973, even the van Willebrand cultured from the human endothelial cells was made available. But nowadays we have plasma-derived van Willebrand factor, which are virally inactivated. This is very, very important because of the viral threat with the product. So viral inactivation using the technology like pasteurization or even moist heat, chemical solvents, that is a must nowadays to prevent the transmission of viral infection. And one more important point I would like to highlight here only, the van Willebrand factor or anti-hemophilic factor, earlier what we now call, so used to be used for treating van Willebrand disease 10 years back, because both factors used to be there together. So but the growing technology, in the interest of purification of the factor 8 to make it still more efficacious, the purification process came into place, and this purification process helped hemophilia patients, but it is a curse for van Willebrand disease patient, because purification process will destroy van Willebrand factor. So that's why whenever you treat a van Willebrand disease, whenever you have a anti-hemophilic factor vial, please check whether it is high purity product or intermediate purity product, or which is not at all subjected to purification, or if the product is specifically van Willebrand factor, because nowadays in 2015-19, so these drugs are also available exclusively to treat van Willebrand's disease. So keep a note, because in our country the most of the AHF available especially if it is recombinant, it is not going to hemophilia, Van Willebrand disease patients. Next slide. So that's why I have put this slide, how to choose the plasma-derived Van Willebrand product. So these are the criteria you need to note down, especially in the treatment of Van Willebrands. That is pharmacokinetic data, the principal active factor, whether it is Van Willebrand, but some factor 8 is also there. But to treat Van Willebrands, predominantly the majority of the factors should be Van Willebrand. Okay, appropriate pharmacokinetic data, that is incremental recovery, half-life of factor, and area under the curve, a mean residence time, and clearance of the factor. These are the points we need to note, because these criteria will act like a surrogate endpoints for efficacy of the product. Okay. Then approved by reputed and local regulatory bodies for use of Van Willebrand disease, and the PI and the label should mention the appropriate approved clinical indication along with the concentration of Van Willebrand factor. The plasma derived factor 8, they just say just it is derived from the plasma. We think that it can be used for treating Van Willebrand disease, but considering this, we should be very careful. And clinical efficacy of the Van Willebrand product should be evaluated in sufficient number of patients, especially type 3 severe Van Willebrand disease, and all these patients, that is generally we call the pharmacokinetic clinical trials. And clinical safety and immunogenicity data as assessed in all patients receiving the Van Willebrand factor product in patients included in the pharmacokinetic trial. So these are some of the points physician need to keep in mind when selecting the product to treat Van Willebrand disease patients. Next slide. So these are the approved product. European Union has approved the Van Willebrand factor and factor 8 licensed products in Europe. But these products, as I told you, they are not so widely available in our country. But fortunately, the Immunate is the product which is available, which contains both factor 8 and factor 9. Factor 8 and Van Willebrand factor, so that we can use in the treatment of Van Willebrand without any hesitation. Next slide. So what is the dosage of these factor concentrates, especially the major surgery? If you are planning 50 units per kg body weight, and once a day for every other day maintenance dosage may be needed, at least for the next 7 days. For minor surgery, 30 units per kg body weight is enough, and once a day or every other day. And factor 8 should be more than 30 units per deciliter for at least 5 to 7 days if you are, especially for any minor surgeries. And dental extraction, the 20 to 40 units per kg body weight is more than enough, and a single dose is more than enough for one tooth extraction. The spontaneous or post-traumatic bleed, 20 to 40% with single dose, we can advise this Van Willebrand factor and factor concentrate. Next one. So titration of dose of Van Willebrand factor and factor 8 concentrates. So this the VWF factor concentrates are dosed on the basis of, yes, this we need to, especially during the surgery, we have to ask for monitor the hemostasis by Van Willebrand factor recoff ratio units, and secondarily basis on the factor 8 units. And it is predicted in vivo recovery in about 1.5 to 2 units per deciliter for each unit per kg body weight of Van Willebrand factor recoff infused, and 2 units per deciliter for each unit per kg body weight of factor 8. So as all of you are aware, 1 unit of factor 8 raises 2% of hemostatic activity. However, individual patient pharmacokinetics varies, and monitoring the Van Willebrand factor Rickoff ratio and factor 8 is recommended during the post-operative or periodically during the treatment. And in vivo recovery may be calculated by the following formula, that is peak Van Willebrand factor Rickoff ratio minus baseline Van Willebrand factor Rickoff ratio divided by the dose, that is units per kg body weight infused. Next slide. So the Van Willebrand treatment strategies, we have discussed this thing, and the last one I have already mentioned, the topical agents and as well antifibrinolytic drugs, that is tranexamic acid and epsilon aminocaproic acid. Next slide. So in case these Van Willebrand factors are not available, or sometimes we may require platelet transfusions, especially in treating type 2B Van Willebrand disease. But if Van Willebrand factor is not available, AHF is not available, cryoprecipitate, which we used to use earlier, is the ideal product which can be obtained from your blood bank. So the dosage and all those, one bag of cryo contains around 100 units of factor 8, and for every 5 kg you can calculate and give the cryoprecipitate. And even if that is not available, if patient is bleeding, the FFP, which contains all the 13 clotting proteins, may be considered. Next one. So in conclusion, Van Willebrand's disease is most common inherited bleeding disorder. However, it is underdiagnosed in India. And diagnosis and classification is a little complex, requiring array of lab tests and physicians' knowledge. Women are also equally affected. While choosing a product for managing Van Willebrand's disease, it is recommended that we choose product with a proven high Van Willebrand factor content. So again, look into the label of the vial, whether it is high purity or intermediate purity. Choose a molecule with a robust clinical data, approved PI indication, and local regulatory approval for Van Willebrand's disease. And the European Union has approved Van Willebrand factor and factor 8 plasma products, which are available even in the government setup, that is Immunate in India, which may be considered in the treatment of Van Willebrand's disease when they come with the bleeding episodes to the government hospital. Improving awareness about the disease, establishment of comprehensive coagulation laboratory and the treatment centers will be successful in increasing the diagnosis of Van Willebrand's disease. As I told you, it is underdiagnosed, so we have to encourage the medical students, postgraduate students to understand the pathophysiology, the available mode of treatment of Van Willebrand's disease to increase the identification. And proper education and counseling of patients and families. And we have a list of Van Willebrand disease patients in our center, and we have made group among themselves, and they meet frequently and discuss their issues. And it is my experience bringing all these inherited bleeding disorders together and allowing them to discuss or express their feelings is most important in addition to the treatment. Next. Yes, this is the comprehensive care center which we have established in Davangere over the period of 30 years, more than 30 years. And at this moment, I would like to take this opportunity to thank all the medical and paramedical professionals who have helped us in setting up this center in Davangere. And especially, I mention about my students who are now studying, and as well the old students. Even now, they are keeping in contact with the center and helping the center. And not only medical and paramedical professionals, even the general public and philanthropists and celebrity like S.P. Balasubramaniam has joined hands with us, and that's how it has become possible for us to provide free treatment to all inherited bleeding disorder. With the support of Government of Karnataka, with the support of World Federation of Hemophilia and Hemophilia Federation, the factors are given totally free of cost to most of our patients. And when we started this, the other inherited bleeding disorders also came in, though it is not a government order, but we have committed to provide all the blood components needed for inherited bleeding disorders, maybe Van Willebrand's, factor 13, factor 10, fibrinogen deficiency, glandular thrombocythemia, any number of units, we are committed to provide them totally free of cost. Only the diagnosis part is not free, because the reagents are very expensive. And again, I thank one and all joining this webinar. And the theme of this year's World Hemophilia Day is get involved. Yes, we need you come forward and get involved in taking care of these patients, and we need your support. I once again thank Takeda for organizing this program to increase the awareness about Van Willebrand disease. Thank you. Thank you very much.
Thank you, sir. Thanks for a very enlightening session on Von Willebrand disease, which is one of the commonest bleeding disorder, though it's found to be rarest among the reported among all the entire the numbers. So there are a few questions from the audience. So
Yes.
I am putting them in the chat box in the private chat. So first among the same is when to suspect Von Willebrand disease.
Yeah. Suspect Van Willebrand disease. Any mucocutaneous bleed. Number one. As I told you, history taking is very important. Okay. Any mucocutaneous bleed, and any bleed which is prolonged, slow, and sustained bleeding. Blood trickles. That is the typical nature of coagulation disorder. Okay. They feel. So this is how they present mucocutaneous bleeds and gum bleed, repeated nose bleed. Okay, and we should take family history, especially anybody else in the family history affected, and the parents, whether they have bleeding episodes or not, and most important, the sex of the patient. Obviously, the female with mucocutaneous bleed, we think Van Willebrand as the first. The male with mucocutaneous bleed, we think hemophilia, and of course, the platelet disorder and other disorders has to be ruled out. And the battery of investigation, initial, that is plasma clotting test, will help us to proceed further.
Thank you, sir. So the next question is, in which age should the factor levels of hemophilia carrier daughters be checked? And does the factor level change in women over time to time?
Actually, the level of the Van Willebrand factor, as I mentioned, is subjected to a lot of variations. Even including, as I mentioned, blood group. Okay. So whereas the level of the factor 8 won't change, and the carrier women, unless in our setup, no carrier women, we give more importance if they are planned for any surgeries. So that time we will we will do our investigation, and under the cover of factor, we allow the surgery to happen. Whereas Van Willebrand's disease patient, so we need to counsel, reassure the patient, and tell the facts, especially the females who wants to become pregnant, and anticipated postpartum hemorrhage, and how to manage it. All these things have to be discussed, and we should provide all the options available for the management of their pregnancy and delivery.
Okay, thank you, sir. There is one more question from the HCP. I have a 12 years old female patient diagnosed with Von Willebrand disease. Her menses cycle has recently started from last month. She now complains of pain and prolonged bleeding episodes. How should I manage her?
This girl actually maybe now she is 12 year. Okay,
Yeah.
most of the Van Willebrand disease, especially type 1, no, they may not manifest till they achieve menorrhagia. Maybe the menorrhagia may be the main factor in her. So what generally we do. So again, reassurance and counseling of both daughter and mother, and generally we go for these anti-fibrinolytic drugs and desmopressin in controlling the bleeding episodes. If it doesn't work, then we will go for hormonal therapy. Hormonal therapy, that is OC pills we give, and control the menstrual cycle bleed. Okay, and if suppose especially the type 3 Van Willebrand disease, there is no other option, then we have to go for replacement of the factor 8 and Van Willebrand complex, that is immunate, which is available, and according to our weight and weight, we have to plan the immunate replacement to control the bleed. And later we can switch over to other modality of treatment until she plans the further management.
Thank you, sir. So next question is, what is the incidence of von Willebrand disease? Why it's neglected in India, and why it's not life-threatening?
Yeah. So I have already mentioned actually why it is underdiagnosed. So even I will talk from patient's perspective also, and how many of our women comes to hospital with the excessive bleeding. So they undermine their menstrual cycle, which is excessive, and they go into anemia and later come to the hospital with severe anemia actually. So that's why the education and the counseling awareness about the menstrual cycle and especially puberty menorrhagia among especially in the college and going girls has to be given. Number one. Number two, the more and more the training and educative programs, maybe in the medical college, maybe in the government hospital, or the HTCs. So we should conduct more and more case-based discussion to train our postgraduates and undergraduate students to diagnose Van Willebrand's disease and provide appropriate treatment. This is number two. Number three, setting up of a lab. Improving. Already medical colleges are having a pathology department. Only we need to make the training available for the technicians and pathologists to conduct the basic coagulation profile and also the platelet aggregometry, especially the ristocetin induced platelet aggregation. So it has to be made available. At least these are the basic necessities. So if these are established, definitely we are going to identify more and more patients and provide them treatment to improve their quality of life.
Thank you, sir. And how can we improve the diagnosis rate in von Willebrand disease?
Diagnosis rate, actually, that's what I was discussing with some. Whenever I go to medical colleges, I try to promote the establishment of comprehensive hemophilia care center. So comprehensive hemophilia care center naturally includes comprehensive coagulation laboratory. So once it is not only hemophilia, in the comprehensive coagulation laboratory, then we can start doing these APTT and the bleeding time at least with the modified IVIS method, and also correction studies and factor 8 assay, and especially in the female, if factor 8 level is low, then you can think of factor the type 3 Van Willebrand disease patient. So at least we can do that. Then you can plan for further investigations with the platelet aggregometry, especially the ristocetin induced aggregation, collagen binding studies, and multimer studies very, very difficult in our setup. At least this panel of platelet aggregometry and Van Willebrand factor antigen assay. Nowadays, even ELISA methods are available. So with the latex agglutination method are also available. At least using these methods, we can improve the diagnosis of van Willebrand. And one more last, so in the medical colleges, there are postgraduates. So we can give them a dissertation or thesis on these inherited bleeding disorder so as to encourage the research and development.
So next question is hemophilia and COVID-19. How can you take care of joints during the lockdown period?
Actually, we have conducted a good number of even a Zoom meeting and tele medicine we have provided to our patients. And especially, I will give an example. One patient had a hematuria. We treated him, even allowing him not to come out of the home. So with plenty of fluids, with one course of antibiotic, everything was subsided. So these are the tips we give to most of our patients to manage their bleeding episodes within the available resources. Number one, if bleeding, significant bleeding, then they have to go for factor replacement therapy. And some of our patients, they have procured factors from the societies and keeping at home. For them, even during the camp, we have educated them about self-infusion and they treat bleeds on their own. But anyhow, this is not majority. But there are certain patients who needs factor infusions. So nowadays, the district hospital has got all the factors available, and we advise them to rush to the district hospital and infuse factor. And if there also any problem, then with the permission of the district authorities, then we advise them to. In addition to all these, then we also advise them to keep lifestyle modification. So regular physiotherapy and the other alternative medicines, naturopathy and yoga methods, pranayama, all these tips we have given to minimize the bleeding episode during this COVID. And what happens if any of our hemophilics contracts COVID-19? In that case, so actually to tell you, hemophilia is not a risk factor for COVID-19. They are also equally at risk when you compare to anybody else in the community. And that's why we have advised all the social distancing and hand washing and all those whatever publicized in the media. So we have stay at home and all those we have advised them very strictly not to come out. So that's why these are. Then if a patient contracts, then it becomes very complex and they should be managed as in any other COVID-19 patient. And only one note I would like to give here is in general, there is a protocol that anticoagulation is required while treating COVID-19. It all depends upon the stage. You know that it varies from asymptomatic to even serious complication. During that time, when anticoagulation is needed, we have to do it under the cover of factor 8. They are in the blood. That is the only caution we need to give to them. Thank you.
Thank you, sir. Thanks for addressing all the questions. And I would like to thank our audience for taking their precious time and attending this webinar. And also would like to thank Dr. Suresh Hanagavadi for enlightening us on the learnings about the von Willebrand disease, its challenges in the diagnosis and management. So definitely it would go ahead in creating the awareness. And I would like to thank the audience and also speaker Dr. Suresh for conducting this webinar. Thanks to all of you for participating and making this event a successful event. Thank you.
I thank one and all for participating.